Foundations of Maternal, Newborn, and Women's Health Nursing by Murray, McKinney, Holub, and Jones, 7th edition. Chapter 15, Nursing Care During Labor and Birth. Care of the woman and her family during labor and birth is a rewarding yet demanding specialty within nursing. Birth is more than a physical event. It is a powerful, life-changing event that leaves a lasting impact on the childbearing woman and her family. Every culture recognizes that birth has deep personal and social significance. Roles and relationships are forever altered by this event. Intrapartum nurse responsibilities include assessing, supporting, documenting, and communicating labor progress to patients, their families, and providers. The nurse must support natural physical processes, promote a meaningful experience for the family, and be alert for complications. Additionally, the nurse cares for two patients, one of whom the fetus cannot be observed directly. Although labor is a normal process, some women require special procedures to help them and their fetuses. This chapter will also address the nursing considerations for some of these procedures. Admission to the birth facility. The decision to go to the birth facility. During the last trimester of pregnancy, the woman needs to know when she should go to the hospital or birth center. Factors to consider include the following: number and duration of any previous labors, distance from the hospital, available transportation, child care needs, and risk status. During prenatal care, nurses teach women to distinguish between false, prodromal, and true labor. Nurses teach guidelines for going to the birth center and reinforce those given by the provider. Not everyone has a typical labor, so a woman should be encouraged to go to the birth center if she is uncertain or has other concerns. Teaching when to go to the hospital or birth center. These are guidelines for providing individualized instruction to women about when to enter the hospital or birth center. Contractions, a pattern of increasing regularity, frequency, duration, and intensity. Nullipara, regular contractions 5 minutes apart, lasting 1 minute for 1 hour. Multipara, regular contractions 10 minutes apart, lasting 1 minute for 1 hour. Ruptured membranes, a gush or trickle of fluid from the vagina should be evaluated, regardless of whether contractions are occurring. Bleeding, bright red bleeding should be evaluated promptly. Normal bloody show is thicker, pink or dark red, and mixed with mucus. Decreased fetal movement. A substantial decrease in the baby's normal activity requires evaluation. Your physician or nurse midwife should be notified or come to the labor unit. Other concerns. These guidelines cannot cover all situations and do not replace specific instructions given to you by your physician or nurse midwife. Therefore, go to the hospital for evaluation of any concerns and feelings that something might be wrong. Nursing responsibilities during admission. Developing rapport, gaining a sense of birth expectations, and assessment of maternal fetal status are three key components of the initial interaction during admission. Establish a therapeutic relationship. Developing rapport. The nurse should quickly establish a therapeutic relationship with the woman and her significant other. The woman's first impression influences her perception of the quality of her entire birth experience. Even when the unit is busy, the nurse should communicate interest, friendliness, caring, and competence. Nurses often encounter women who speak a language other than English. Arranging for a culturally acceptable interpreter makes the woman and her family feel welcome, promotes safety through enhanced understanding, and meets regulatory standards. Offer interpreters via telephone, online service, or in person when available. Convey confidence. From the first encounter, the nurse should convey confidence and optimism in the woman's ability to give birth and the ability of her significant others to support her. Women having their first baby may be overwhelmed by the pain associated with labor. The nurse can reassure these women that intense contractions are normal in active labor, while helping them manage the pain and watching for complications. Assign a primary nurse. Having one nurse provide all care during labor is ideal but often unrealistic. However, changes in caregivers should be limited. Explanation of caregiver roles is important. Use touch for comfort. Touch can communicate acceptance, offer reassurance, and provide physical and emotional comfort to many laboring women. Women who usually do not welcome touch may appreciate it during labor. Cultural norms and personal history influence a woman's acceptance of touch from an unrelated person. The nurse should not assume the woman desires touch, but instead ask her if she welcomes or benefits from touch. As labor progresses, the woman's desire for touch may change. It may become irritating rather than comforting. Respect cultural values. Cultural beliefs and practices give structure, meaning, and richness to the birth experience. They influence the behavior of both the childbearing family and the professional staff. Most cultural groups have specific practices relating to childbearing. The nurse should incorporate a family's cultural practices into care as much as is safe and possible. Determine family expectations about birth. Regardless of their number of children, women and their partners have expectations about birth experience. Whereas some women use birth plans describing what they desire, others may not have specific plans but have expectations shaped by contact with relatives, friends, previous birth experiences, and the media. An individualized birth plan brought to the hospital is a great communication tool to help the team meet the woman's birth expectations. If the woman does not have a specific birth plan, the nurse should use open-ended questions to identify the expectations of the woman and her family. Assessment of maternal fetal status. The assessment of the obstetric patient is an ongoing, multidimensional process that begins with admission and continues throughout the hospital stay. The admission process includes performing a physical examination, reviewing the woman's medical, surgical, and obstetric history, performing a psychosocial assessment, and asking about personal preferences for labor and birth. This inquiry includes both the patient's perspective and that of her support system. Assessment does not end with the completion of the admission intake process. The obstetric registered nurse continually assesses maternal fetal status while supporting the woman and her family throughout the antenatal, birth, and postpartum periods. The prenatal record serves as a communication tool between the provider and the birth facility. Information obtained from the prenatal record is verified or updated as needed. Have not had prenatal care or who have received care from a provider who practices at a different facility need more extensive assessment by the nurse and provider. Assessment. On admission, the focused assessment is performed before the broader database assessment is completed. Assessment priorities are set by the condition of the mother and fetus and whether birth is imminent. This assessment includes, at a minimum, the patient's chief complaint, assessment of the fetal heart rate, maternal vital signs, and uterine contractions/labor progress. Fetal heart rate. For assessment of a term fetus using intermittent auscultation, following fetal heart rate guidelines are considered normal. Category 1. A baseline rate of 110 to 160 BPM. Regular rhythm. Absence of decreases from the baseline. Presence of increases from the baseline. If electronic fetal monitoring is used, additional characteristics including fetal well-being include the following. Presence of accelerations in the FHR baseline may be present. Presence of pathologic, late, variable, or prolonged decelerations. Moderate variability. Maternal vital signs. Maternal vital signs provide insight into well-being of both the mother and the fetus. They identify complications such as hypertension or infection. Hypertension during pregnancy is defined as a blood pressure increase of 140 systolic or 90 diastolic or higher. Hypertension may be transient, related to pregnancy, or chronic. Of 38 Celsius, 100.4 Fahrenheit, or higher suggests infection. Tachypnea, hypotension, and tachycardia also can be associated with varying degrees of maternal complications such as infection, respiratory distress, or blood loss. Impending birth. Grunting sounds, bearing down, sitting on one buttock, and saying urgently, "The baby's coming," suggest imminent birth. In this situation, the nurse abbreviates the initial assessment and collects other information after birth. While the nurse cares for the mother, pertinent critical information can be quickly gathered if birth is imminent. Names of mother and support persons. Name of her provider if she has prenatal care. Number of pregnancies and prior births, including whether the births were vaginal or cesarean. Status of membranes. Expected date of delivery. Problems during this or other pregnancies. Significant medical and surgical history. Allergies to medications, food, or other substances. Time and type of last oral intake. Maternal vital signs and FHR. Pain, location, intensity, factors that intensify or relieve, duration, constant or intermittent, whether the pain is acceptable to the woman. The provider is notified promptly if any of the following are identified or suspected. Imminent birth, Category 2, or abnormal, Category 3, FHR. Abnormal vital signs, vaginal bleeding, preterm labor, preterm premature rupture of membranes, acute abdominal pain. Database assessment. If focused assessments of mother and fetus are normal and birth is not imminent, a more complete admission assessment is performed to further assess the mother, fetus, and available maternal support persons. Basic information. Regulatory agencies and defined standards of care require certain elements to be addressed on admission to the hospital. Intrapartum admissions forms guide the nurse to obtain required information. Typical information includes the following. Chief complaint, reason for coming to the hospital or birth center, e.g. contractions, rupture of membranes, decreased fetal movement, headache. Prenatal care, when it began, her most recent visit, and the name of her provider. Estimated date of delivery, EDD, also may be abbreviated EDB, estimated date of birth. Number of pregnancies, births, or spontaneous or elective abortions. Allergies, medications, food, or other substances such as latex. Last solid food and oral intake, what time it was consumed. Medical, surgical, and pregnancy histories. Recent illness, including treatment. Medications, including prescription and over-the-counter drugs, tobacco, alcohol, and other substances of abuse. Complementary or alternative therapy, or use of herbal and botanical preparations and the purposes. The woman's subjective evaluation of her labor. Birth plans, including planned pain management methods. Support persons, who they are, and the role of each. Domestic violence, risk or history of. Ask only when the woman is alone. Psychosocial well-being, including history of depression, anxiety, or suicidal risk. Other important aspects, including assessment of nutrition, resources at home, level of education, and learning style. Women often bring several people with them to the birthing room and want them to stay during admission. Caution is prudent when asking about sensitive information such as prior pregnancies, sexually transmitted infections, and potential abuse when others are present. The woman's partner and other visitors may be unaware of her history. Delay asking intimate information until the woman is alone for confidentiality, safety, and accuracy. Physical examination. A physical examination evaluates the woman's overall health and covers important observations relating to pregnancy, including the presence and location of edema, abdominal scars, and the height of the fundus. Fetal assessments. The fetal presentation and position are assessed using a combination of vaginal examination and Leopold's maneuvers. PR is assessed by intermittent auscultation or electronic monitoring. Labor status. The woman's labor status is determined by assessing her contraction pattern, performing vaginal examination, and determining whether her membranes have ruptured. A sudden gush or steady leakage of fluid from the vagina may indicate ruptured membranes. If there is doubt, vaginal fluid may be tested for pH or examined under a microscope for the presence of ferning. The nurse documents the time of rupture, color, amount, and odor of the amniotic fluid. Contractions are assessed by palpation or via the electronic monitor. Cervical dilation, effacement, station, fetal presentation, and position are evaluated by vaginal examination. The vaginal examination also may reveal whether the membranes have ruptured if fluid is not obviously leaking from the vagina. Vaginal examination is not performed if a woman has active bleeding, other than bloody show. Speculum rather than vaginal examination may be done if the gestation is preterm or if active bleeding is present. Admission procedures. Notify the provider. After assessment, the nurse notifies the woman's obstetric provider to report the woman's status and obtain orders. The following data are provided. The woman's name and age, gravidity, parity, term and preterm births, abortions, spontaneous and elective, and living children, and fundal height if it conflicts with the date, contraction pattern, results of vaginal examination, cervical dilation and effacement, fetal presentation and position, station of the presenting part, membrane status, FHR and uterine activity pattern, maternal vital signs, history including medical, surgical, and obstetric findings, any identified abnormalities and concerns about the maternal or fetal condition, pain, anxiety, or other reactions to labor, birth plans. Consent forms. The woman signs consent for care during labor, such as anesthesia, vaginal birth, and cesarean birth, induction, oxytocin, cervical ripening, and blood transfusion. In birth, induction and blood transfusion are not anticipated. Many facilities include these procedures in admission consents because of the potential emergent nature of complications during labor. If the woman requests postpartum sterilization, consent may be required before labor and verified at the time of birth, with the emphasis that permanent sterility is expected after bilateral tubal ligation. Consent for newborn care and circumcision are often completed on the woman's admission to the birth facility. Laboratory tests. Common laboratory results needed on admission to the labor and delivery unit include complete blood count, blood type, HIV screen, hepatitis B surface antigen, venereal disease research laboratory, or rapid plasma reagent tests for syphilis, rubella titer, and midstream urine specimen to assess protein, glucose, and ketones. Women who receive prenatal care may have laboratory results available on the prenatal record. STI testing are recommended by the state health department in collaboration with the obstetric provider may order additional tests pertinent to the patient's presenting complaint and medical history. When there is no prenatal record available on admission, more extensive testing may be required. IV access. If ordered, IV access is started with a large bore 18-gauge catheter. A saline lock may be used, or the woman may receive a continuous infusion of fluids. The saline lock allows freedom of movement when walking during early labor, but provides quick access if fluids or medications are needed. Continuous fluid infusion reduces dehydration and is necessary if epidural analgesia is used. IV solutions containing electrolytes, such as lactated Ringer solution, are the most common fluids administered. Ongoing assessments. If it is unclear after the initial assessment whether the woman is in true labor, the woman may be observed. After 1 or 2 hours, progressive cervical change, effacement, dilation, or both, strongly suggests true labor. After the admission assessment, the woman and fetus need ongoing evaluations based on their risk status to promote well-being and minimize the risk for iatrogenic harm and avoid unnecessary interventions. General guidelines for continuing assessments are listed here. Maternal assessments. Labor progress. The frequency of vaginal examinations depends on the woman's parity, status of her membranes, and overall speed of her labor. Examinations are limited to avoid the introduction of microorganisms from the perineal area into the uterus. Pressure of the fetal head on the rectum in late labor makes many women feel the need to have a bowel movement. The nurse should look at the perineum for crowning, appearance of the fetal scalp or presenting part at the vaginal opening, and perform a sterile vaginal examination if the woman suddenly expresses an urge to push or have a bowel movement during a contraction. Contractions. Normal UA during labor includes less than or equal to 5 contractions in a 10-minute window. Contractions can be assessed by palpation or with the electronic fetal monitor. As defined by National Institute of Child Health and Human Development, excessive UA leads to progressive fetal decompensation, secondary to inadequate blood flow to the interval space comprising fetal gas exchange and a resultant increased risk for development of fetal acidemia. The goal is to maintain normal UA by intervening for any cases of excessive UA. Output. Oral and IV intake and each void are recorded. Labor may reduce a woman's urge to void, therefore her suprapubic area should be checked every 2 hours or more frequently to identify bladder distension. Response to labor. The woman's behavioral responses change as labor intensifies, especially if she has not had epidural analgesia. Often this response is determined by cultural expectations. She may withdraw from interactions but need more nursing presence and reassurance. She may experience anxiety for any number of reasons: pain and fear of bodily injury, unknown outcome, loss of control, unresolved psychological issues that influence her readiness to give birth, e.g. sexual abuse, previous birth experiences, or unexpected occurrences during labor. Anxiety has been associated with increased catecholamine release that can cause dysfunctional labor/ineffective UA. Women experience a broad range of emotions that can affect their ability to cope with labor. Interventions to assist the woman include both non-pharmacologic and pharmacologic measures. The goal of nursing care is to support the woman's desires and manage her pain, while not interfering with her labor progress or causing adverse outcomes for the woman or fetus. Roberts, Gulliver, Fisher, and Cloyes developed an algorithm for assessing a woman's ability to cope with labor as an alternative to the traditional pain scale of 0 to 10. Signs of coping include the following: states she is coping, focused inward, has rhythmic motion and breathing patterns, able to relax between contractions. Behaviors that suggest the woman may not be coping with labor include the following: specific requests for medication and other pain control measures such as epidural analgesia, statements that current measures are ineffective, tension of her muscles and arching of her back or panicked activity during contractions, crying, tearfulness, tremulous voice, a tense facial expression, rolling in the bed. She is not coping, may use expressions such as "I can't take it anymore." Labor support plays an integral role in perinatal outcomes. The 2013 Cochrane Database Review on Continuous Labor Support During Childbirth looked at 22 trials involving over 15,000 women. They found the women who had continuous labor support were more likely to have shorter labors without analgesia that resulted in spontaneous vaginal delivery. They were less likely to have operative vaginal births or infants with low 5-minute APGAR status or report dissatisfaction with the birth experience. This review also stated that support was most effective when it was delivered by someone other than hospital staff. Therefore, the inclusion of the woman's support system is integral to her labor. Support person's response. Labor can be stressful for the woman's partner/support person. Often the person may become anxious, fearful, or tired. The person may feel a responsibility to protect and support the woman, but may have limited resources for doing so. Watching the woman in pain is difficult, even if the pain is normal. The support person may respond to stress in many ways, including being quiet, suffering silently, or reacting with pacing and anger. At times, the person may respond by leaving the room frequently or for long periods, whereas others resist even short breaks. Cultural norms may dictate that the father's presence during labor and birth is strictly prohibited. The father may be pulled in two directions, wanting to be included but hesitating because men in his culture are not customarily involved in birth. The nurse should respect the values of each couple and their wishes about paternal involvement. The support person also may be the woman's parent, another relative, friend, or significant other. The nurse should remember that anyone who assists a woman during labor may have feelings of anxiety and helplessness at times. Reassurance and care for the labor partner strengthen the person's ability to support the woman and enhance the likelihood that both will view the birth experience as positive. Fetal assessments. Assessments are performed to identify signs of well-being and those that suggest compromise. The principal fetal assessments include FHR patterns and character of the amniotic fluid. Abnormalities revealed in these assessments may be associated with impaired fetal gas exchange and infection. Fetal heart rate is assessed using either intermittent auscultation or EFM. Frequency of assessment and documentation depends on the risk status of the mother and fetus and the stage of labor. FHR assessments are recommended before and after procedures or interventions that might change the intrauterine environment or the relationship of the fetus to its environment. Some examples include rupture of membranes, spontaneous or artificial, ambulation of the patient, administration of analgesia or anesthesia, administrations of induction agents, or vaginal examination. This assessment and documentation of fetal status allows the clinician to demonstrate the response to procedures/interventions. Fetal membranes and amniotic fluid. Spontaneous rupture of membranes, SRAM, may occur, or the provider may perform an amniotomy. Amniotomy, artificial rupture of the membranes, or AROM, is usually performed in conjunction with induction, artificial initiation, or augmentation of labor, artificial stimulation of uterine contractions, and to allow internal EFM. The time of rupture FHR, color, odor, and quantity of the amniotic fluid are noted and charted. The fluid should be clear and may include bits of vernix, the creamy white fetal skin lubricant, and have a mild musty smell. A large amount of vernix in the fluid suggests that the fetus may be preterm. Greenish meconium-stained fluid may be seen in response to transient fetal hypoxia, post-term gestation, or placental insufficiency. Fluid with a foul or strong odor, cloudy appearance, or yellow color suggests chorioamnionitis, inflammation of the amniotic sac usually caused by bacterial or viral infections. Quantity of fluid should be described in approximate terms. For example, at term, a large amount is more than 1,000 milliliters. A moderate amount is approximately 500 to 1,000 milliliters, and scant amniotic fluid is a trickle, barely enough to detect. If the fetus is engaged in the pelvis when the membranes rupture, a small amount of fluid in front of the fetal presenting part may be discharged, forewaters or forebag, with the rest lost at birth. Polyhydramnios, excessive volume of amniotic fluid, is associated with some fetal abnormalities. Oxygenation, abnormally small quantity of amniotic fluid, may be associated with placental insufficiency or fetal urinary tract abnormalities. AROM and SROM are associated with risks that the nurse must observe for, including prolapse of the umbilical cord, infection, and placental abruption of the umbilical cord. The primary risk at the time of rupture is that the umbilical cord will slip down in the gush of fluid. The cord can be compressed between the fetal presenting part and the woman's pelvis, obstructing blood flow to and from the placenta and reducing fetal gas exchange. The FHR is assessed for at least 1 full minute after amniotomy or SROMs. Indeterminate or abnormal patterns or significant changes from previous assessments are reported promptly to the provider. Cord compression is usually accompanied by variable or prolonged decelerations or a bradycardic FHR. Infection. With interruption of the membrane barrier, vaginal organisms have free access to the intrauterine cavity and may cause chorioamnionitis. The risk is low at first, but increases as the interval between membrane rupture and birth increases. 24% of patients will develop chorioamnionitis with rupture of 24 hours or longer. Rates of up to 60% incidence with pregnancies that are remote from term. 24 hours of membrane rupture is desirable, although infection does not occur at any absolute time. Placentae, also known as placental abruption, can occur if the uterus is distended with excessive amniotic fluid when the membranes rupture. The uterus collapses with discharge of the amniotic fluid. The area of placental attachment shrinks. The placenta then no longer fits its implantation site and partially separates. A large area of placental disruption can significantly reduce fetal oxygenation, nutrition, and waste disposal. Nursing considerations. Assisting with an amniotomy. Obtain a baseline FHR via electronic monitoring or auscultation before amniotomy is performed. The initial fetal assessment provides a baseline to compare with later assessments. Before amniotomy, 2 or 3 underpads should be placed under the woman's buttocks to absorb the fluid. The underpads should be overlapped to extend from her waist to her knees. A folded bath towel under the buttocks absorbs more amniotic fluid. Explain to the woman that amniotomy is no more painful than a vaginal examination because there are no sensory nerves in the amniotic sac. Other supplies needed are a sterile, disposable plastic hook, such as AmniHook, sterile gloves for the provider, and sterile lubricant. The nurse should partly open the package containing the plastic hook at the handle end and hold back the package until the provider takes the hook. Performs a vaginal examination to determine cervical dilation, effacement station, and fetal presenting part. It is often deferred if the fetal presenting part is high or the presentation is not cephalic. The risk for a prolapse cord is higher in these situations. The hook is passed through the cervical opening, snagging the membranes. The opening in the membranes is enlarged with the finger, allowing fluid to drain. Application of the nursing process, false or early labor. Assessment. After observation, the nurse may realize that the woman is not in true active labor. If findings are normal and the woman's membranes are intact, she is usually discharged. The woman who is in very early latent labor may be discharged to await active labor, especially if she is a nullipara and lives nearby. Identification of patient problems. A woman may be frustrated because she cannot tell whether labor is real. She may resist returning to the birth center, possibly causing needless delay of care. She often is tired of being pregnant and just wants it to be over. There is often a need for patient teaching regarding the characteristics of true labor. Planning expected outcomes. An expected outcome for this patient problem is that before discharge, the woman and her support person will describe reasons for returning to the birth center for evaluation. Interventions. Reassurance. A woman sent home after observation may feel foolish and frustrated. She may want to have labor induced simply to get it over with. Reassure her that even professionals cannot always distinguish true and false labor. Also tell her that important preparation for labor occurs during late pregnancy, such as softening of the cervix, even if obvious progress, such as cervical dilation, has not yet occurred. Early latent labor may gradually intensify as it merges into the active phase of first stage. Other women may notice a more abrupt intensity and frequent change as the latent phase becomes active labor. Teaching. Review guidelines for returning to the birth center and explain that these are only guidelines and she should return if she has any concerns. Returning with false labor is better than entering in advanced labor or developing complications at home. Remind her that her body is often making the final preparations for birth. Evaluation. The woman and her support person should describe guidelines for returning to the birth center. These include regular contractions, leaking of amniotic fluid, bleeding other than bloody show, and decreased fetal movement. Application of the nursing process. True labor. The admission assessment may confirm that the woman is in true labor, or true labor may be evident after observation. Patient problems change during labor because the intrapartum period is an active process. Problems covered in this chapter relate to fetal oxygenation, maternal discomfort, and maternal injury. Patient problems often have an impact on each other during labor. For example, high anxiety reduces effectiveness of pain relief measures by interfering with relaxation. Maternal dehydration can alter fetal oxygenation because less blood is available to circulate to the placenta. Fetal oxygenation. Assessment. The critical assessments related to fetal well-being are the following. FHR evaluation, amount and character of amniotic fluid and time of rupture, maternal vital signs, contractions, frequency, duration, intensity, relaxation interval, and resting tone. Identification of patient problems. Several factors such as maternal hypotension and hypertension, maternal fever, excessively strong and long contractions, tetanic, and compression of the umbilical cord can reduce fetal oxygen, nutrient, and waste exchange. The healthy fetus usually tolerates labor well, and the nurse simply needs to be alert for problems. Therefore, the potential for fetal compromise is a patient problem in all labors. Planning, expected outcomes. Planning includes nursing responsibilities to 1. Promote normal placental function, and 2. Observe for and report problems to the provider. The expected outcome is that the fetus does not show signs of compromise such as Category 3, abnormal, FHR patterns. Interventions. Promote placental function. Maternal positioning is the primary measure to promote placental perfusion during normal labor. The supine position should be avoided because it causes the woman's uterus to compress her aorta and inferior vena cava, aortocaval compression, reducing blood flow to the placenta. If she must be in the supine position for a procedure such as catheterization, a small pillow or folded blanket under one hip shifts her uterus to maintain a placental blood flow. Observe for conditions associated with fetal compromise. If conditions associated with fetal compromise are identified, provide interventions directed at the most likely physiologic cause and notify the provider. Evaluation. Throughout labor, compare actual data with the norms for mother and fetus. The outcome criteria has been met if the fetus does not develop signs of compromise. Discomfort. Women vary in their responses to labor pain and choices of pain management methods. Providing choices for pain management and support for those choices allows an increased sense of control over her birth experience. The woman who successfully masters the pain and other physical demands of labor is more likely to view her experience as positive. Her support person also is likely to feel more satisfaction with the experience. Working with people in pain is difficult, and most nurses feel compelled to relieve pain promptly. Yet pain is expected and has a purpose in labor. It cannot be eliminated. The nurse's role is to teach the patient and her support person about various methods of pain management, and then support her decisions and evaluate her responses. Assessment. See Table 15.1 for continuing assessments of the laboring woman. Specific data applicable to discomfort include the birth plan, identification of support persons, and any preparation for childbirth. If the woman has had previous births, assessment of the pain management methods used and their effectiveness is important. Identification of patient problems. Pain and anxiety are related patient problems. Excess anxiety reduces pain tolerance, and pain worsens anxiety. The nurse clusters assessment data to determine the primary problem. For example, several cues such as previous poor experience during birth and expressions of worry and concern suggest that anxiety is primary. However, if contractions are intense and labor is progressing quickly, the primary problem would be pain. This discussion will focus on the primary problem of pain, which may be due to ineffective use of pain management techniques. Planning. Expected outcomes. The elimination of labor's pain is not realistic. Therefore, appropriate goals and expected outcomes related to pain include the following. 1. During labor, the woman will state that her chosen method or methods of pain management are satisfactory and will tell the nurse if others are needed. By discharge from the birth facility, the woman's support person will express satisfaction with having provided labor support. By discharge from the birth facility, the woman will describe her birth experience as positive. Interventions. Labor pain management includes pharmacologic and non-pharmacologic measures such as breathing techniques and medication to promote comfort and specific methods to relieve pain. See Chapter 13. Provide comfort measures. Comfort measures such as environmental control, hygiene, positioning, and assistance with avoiding affect the woman's ability to relax, which enhances the effectiveness of all pain management techniques. Lighting. Soft indirect lighting is soothing, whereas a bright overhead light is irritating. Bright light implies a hospital, sick atmosphere rather than a normal event such as birth. A bright overhead light should be used only when needed. Temperature. Labor is hard work, and the woman in labor is often hot and perspiring. Cool, damp washcloths on the woman's face and neck can provoke comfort. Other interventions include placing socks if her feet are cold, or using a fan to circulate air in the labor room. Be sure that the fan does not blow on the infant after birth, which might cause hypothermia. Cleanliness. An amniotic fluid leak from the woman's vagina during labor. Change the sheets and gown as needed to keep her dry and comfortable and to reduce microorganisms that might ascend into the vagina. A folded towel or bath blanket absorbs larger quantities of amniotic fluid than the pad alone. Patient preferences guide nursing care. Therefore, interventions to assist the patient may be delayed. For example, during transition, many women may not want to be disturbed. Oral care. Frozen juice bars and hard candy on a stick reduce the discomfort of a dry mouth. And simply rinsing the mouth are helpful to the woman. Lip balm will provide needed moisture to her lips. A full bladder intensifies pain during labor and can delay fetal descent. It may cause pain that remains after an epidural is started. Remind the woman to empty her bladder and check her suprapubic area at least every 2 hours. Catheterization may be required for some patients. Positioning. Clinician preferences and the patient's cultural background influences the positioning women choose when laboring. Encourage the woman to assume any position she finds comfortable, other than supine, and change positions frequently. Frequent position changes in labor decrease pain, improve maternal fetal circulation, improve the strength and effectiveness of contractions, decrease the length of labor, facilitate fetal descent, and decrease perineal trauma and episiotomies. Zwelling, 2010, recommended that nurses follow 6 physiologic principles related to maternal positioning in labor proposed by Fenwick and Simkin. Promote spinal flexion, promote an increase in the uterospinal drive angle, facilitate stronger expulsive forces, promote a good fit, increase pelvic diameter, and facilitate occiput posterior rotation. By encouraging upright positions, frequent position changes, and a C-shaped spine with the mother leaning forward, the nurse can follow these principles. Labor is common when the back of the fetal head puts pressure on the woman's sacral promontory, occiput posterior position. The discomfort of back labor is difficult to relieve with medication alone. Positions that encourage the fetus to move away from the sacral promontory, such as those in which the mother uses the hands and knees position or leans forward over a birthing ball, reduce back pain and enhance the internal rotation mechanism of labor. Smaller versions of the birthing ball are available for use when the mother is sitting and leaning forward. Although ambulation in some positions may not be safe for the woman with an epidural, many options are available by using the flexibility of modern birthing beds with leg supports, squatting bars, and multiple positions of the head and foot sections. Utilization of the peanut ball to assist with positioning has been shown to decrease the time of first and second stage labor in primiparous women with epidurals and decrease the incidence of cesarean section in these patients. Nursing care of the woman with an epidural includes assisting the woman with position changes every 30 to 45 minutes. Teaching. Teaching the woman in labor is a continuously changing task based on the progress of her labor, preferred pain management methods, and their effectiveness. First stage. First stage labor is divided into two categories, latent and active. Women become discouraged because several hours are needed to reach 4 to 5 centimeters of cervical dilation. The latent phase of first stage can last from hours to days. From a time standpoint, 5 centimeters is approximately 2/3 of the way through first stage labor because the rate of dilation increases during the active phase. Patient teaching during the first stage includes keeping the patient informed of the progress of labor, her status, and the status of the fetus. Also should teach the patient about alternative pain management options if her chosen methods do not meet her expectations. A woman's urge to push can occur on complete dilation and effacement with the fetus at +1 station or lower. However, as she nears the second stage, the fetus may descend enough to give her an urge to push before full cervical dilation. This urge is triggered by the presenting part stretching the pelvic floor muscles and is commonly referred to as the Ferguson reflex. This process releases endogenous oxytocin, stimulating an urge to push. The timing of pushing should be individualized by the maternal response. Pushing against a cervix that does not easily yield to pressure from the presenting part may result in cervical lacerations or cervical edema, which can block labor progress. If the woman has a strong urge to push, but pushing is likely to injure her cervix or cause cervical edema, teach her to exhale in short breaths. Second stage. Discomfort in the second stage of labor is associated with pushing. She may need help to trust the sensations from her body and push most effectively. Patient teaching for this stage of labor includes when to start pushing, positions for pushing, and the method for pushing. Nursing research on labor support is increasing and has resulted in inclusion of care based on solid evidence. Laboring down. 2 hours was once accepted as the upper limit for the duration of the second stage, with little evidence of the benefits of restricting the duration of second stage or the accuracy of this time limit. A second stage longer than 2 hours is now recognized as safe, provided the mother and fetus show no signs of compromise. Women push most effectively when they feel the reflex urge to do so as the fetus descends. Women with regional analgesia may not have an urge to push. Many women do not immediately feel the urge to push when the cervix is fully dilated, even if no regional analgesia such as an epidural is administered. A brief slowing of contractions often occurs at the beginning of the second stage. Pushing as soon as complete dilation is achieved with no regard to maternal readiness can lead to issues such as maternal exhaustion and pelvic floor injuries. The technique of delaying pushing until the reflex urge to push occurs may be called delayed pushing, laboring down, rest and descend, and passive descent. Active pushing is the most physiologically stressful part of labor for the fetus. Delayed pushing has been shown to result in less maternal fatigue, decreased pushing time, decreased risk for instrument-assisted and cesarean births, and APGAR scores equivalent to those of women who pushed immediately on full cervical dilation. Simply put, laboring down means allowing uterine contractions to cause most fetal internal rotation and descent after full dilation. The woman rests before actively pushing her baby out. If no fetal descent has occurred after 2 hours, an evaluation by the midwife or physician is necessary. Positions. Although vertical maternal positions enhance fetal descent and shorten labor, often the patient is placed in a recumbent position for provider convenience. Squatting is an ideal position for pushing because it enlarges the pelvic outlet slightly and adds the force of gravity to the mother's efforts, which is an advantage if she has a small pelvis or the fetus is large. If the mother is too tired to squat, the toilet can be used for support while maintaining an upright, open pelvis position. Pushing while sitting on a birthing ball, pulling against a squatting bar on the bed, or playing tug of war with another person provides a similar gravitational advantage. Women may find that pulling on something from above is efficient. Her upper torso should be in front of her pelvis to allow her coccyx to move backward as the fetus descends deeply into her pelvis. Epidural analgesia may limit the positions a woman may assume for pushing. However, with modern birthing beds, many modified positions are safe and effective with or without epidural analgesia. If the mother pushes in the sitting or semi-sitting position, teach her to curve her body around her uterus in a C shape, rather than arching her back. For greatest effectiveness, the woman should pull on her knees, handholds, or a squat bar while pushing. She should maintain a similar C shape to her upper body if she pushes on her side. Method and breathing pattern. Support the woman's spontaneous pushing techniques if they are effective. The woman should push with her abdominal muscles while relaxing her perineum. If she needs coaching, teach her to begin by taking a breath and exhaling it, and then another breath and exhaling while pushing for 6 seconds at a time. Sustain pushing while holding a breath, Valsalva maneuver or purple pushing, or pushing more than 4 times per contraction reduces blood flow to the placenta, increases intrathoracic pressure, is fatiguing, and should be discouraged. Another deep breath that is more like a sigh helps her relax after the contraction. A woman who is modest or fears losing control may inhibit her best pushing efforts if she is instructed to push as if she were having a bowel movement, particularly if she is in a bed or a chair. An anatomically correct image is to teach the woman to push down and out under her symphysis pubic bone, following the pelvic curve. Seeing a diagram or model of the pelvis helps her visualize the curve. Encouragement. Women who receive continuous support in labor have improved outcomes compared to women who do not have support. Laboring women need the support of a skilled, empathic, and intuitive nurse at the bedside, coaching them, reassuring them, and most of all, being there for them. Tell the woman when her labor is progressing. If she can see that her efforts are effective, she has more courage to continue. Help her touch or see the baby's head with a mirror as crowning occurs. Praise the woman and her support person when they use breathing and other coping techniques effectively. This reinforces their actions, gives them a sense of control, and conveys the respect and support of the nurse. If one technique is not helpful after a reasonable trial, 3 to 5 contractions, encourage them to try other techniques. Although the woman and her support person may have prepared for childbirth, they often welcome suggestions and affirmation from the nurse. They are more likely to use the techniques they learned if the nurse helps them. The nurse's presence, gentle coaching, and encouragement help the woman have confidence in her own body and fitness to give birth. Offering pharmacologic measures. Childbirth is a normal process. However, many women desire pharmacologic pain management. The nurse must be informative but neutral when explaining available pain medication. Some women may have a firm goal to avoid pain medication during labor. A woman who planned an unmedicated birth may interpret the nurse's information about available medication as pressure from her to take the medication. Careful review of the woman's birth plan and specific teaching or review of available options establish a therapeutic relationship with the woman, her coach, and the nurse. This should be done as early in the labor as possible while the woman is still in control and can think critically. The discussion should include the option for the woman to change her mind and how that will be communicated. Other women may plan to use a specific method such as epidural analgesia. At times, labor does not go as planned, and the woman may be upset about this unexpected development in her birth experience. Although the event may not be what she wanted, encouraging the woman to express her feelings helps her put it into perspective. Care for the birth partner. The woman's support person is an integral part of her labor care. Her labor partner can provide care and comfort that support the woman's ability to give birth. Some partners are coaches in the true sense of the word, actively assisting the woman through labor. Others want the woman and nurse to lead them and tell them how to help. They are eager to do what they can but expect instructions about methods and timing. Many couples see the partner's role as encouraging, offering moral support, and simply being there for the woman. Caring for the support person includes respect for the couple's wishes about partner involvement and the birth process. The nurse should provide support that the partner cannot and should consider the partner's physical needs for food and rest. Achievement of the 3 goals or expected outcomes occurs if the following conditions are met. 1. The woman indicates satisfaction with her method of pain management or requests nursing assistance to find other, more satisfactory methods. 2. The woman's support person expresses satisfaction with having provided labor support by the time of discharge. 3. The woman describes her birth experience as positive by the time of discharge. The first goal regarding pain management is continually reevaluated throughout labor. The ability of the woman's support person is also continually evaluated. The last goal, describing the birth experience as positive, is evaluated after the woman and her significant other have had time to begin putting the birth experience into perspective. Prevent injury. Assessment. Nursing assessments of the mother and fetus continue as the woman nears birth. During the second stage, observe the woman's perineum to determine when to make final birth preparations. The exact time for final birth preparations varies according to woman's parity, overall speed of labor, and fetal station. Preparations are usually completed when fetal head begins to crown in the nullipara. The multipara is prepared sooner, usually when her cervix is fully dilated and the fetal head is well down in the pelvis, typically before crowning has occurred. Identification of patient problems. The woman is vulnerable to injury immediately before and after birth for several reasons. 1. Altered physical sensations such as intense pressure and effects of medication. 2. Positional changes for birth. 3. Unexpectedly rapid progress. Planning. Expected outcomes. The nurse's primary objective is to prevent and minimize potential injuries. The goal or expected outcome for this problem is that a woman does not have a preventable injury such as muscle strains, thrombosis, and lacerations during birth. Interventions. Positioning the woman in the birthing bed is the first step in the sequence of events that culminates in the birth of the baby. During the period around birth, the nurse reduces factors that contribute to maternal injuries. Transferring to a delivery room. Most vaginal births occur in a combination labor, delivery, and recovery room. Occasionally, the woman must be transferred to a separate room for the birth. If so, she should be transferred early to avoid rushed last-minute preparations that cause anxiety for everyone. Positioning for birth. Upright positions promote effective pushing and take advantage of gravity. Squatting is a good position for uncomplicated birth, but limits accessibility to the woman's perineum and may not be an option for women with epidural analgesia. Maternal positions with the upper body leaning forward promotes expulsive efforts, directs the fetus efficiently toward the pelvic outlet, and increases the diameters of the pelvic outlet. Other upright positions for the birth include standing and kneeling upright positions. The semi-recumbent position limits movement of the coccyx as the fetus descends during birth but maintains some advantages of gravity. Sitting on a birthing bed with a cutout for the perineal area maintains many advantages of squatting and may be less tiring. The hands and knees position may be helpful for the fetus, the occiput posterior position, and to rotate wide fetal shoulders. Many women and providers are more comfortable using stirrups and footrests to support the woman's legs and feet and make her perineum more accessible. If she cannot move her legs because of motor block from anesthesia, raise and lower her legs together and do not separate them too widely. Surfaces that contact the popliteal space behind the knee should be padded. Pressure on veins near the surface could lead to thrombus formation. The woman's upper body should be in the semi-Fowler's or sitting position rather than the supine position. Observe the perineum. The exact time at which a woman is ready to give birth is an educated guess. Birth is near when the fetal head progresses anteriorly in the mechanism of extension and the occiput moves under the symphysis pubis. Observe the woman's perineum, especially during late second stage labor. A classic sign of imminent birth is the mother's urgent cry, "The baby's coming." Look at her perineum, and if the baby will be born before the provider arrives, remain calm and support the infant's head and body with gloved hands as it emerges. Ask the support person to push the call button to summon help. Evaluation. The goal or expected outcome for this patient problem is evaluated throughout the postpartum period because injuries such as muscle strains or thrombus formation are not evident until later. The provider notes lacerations after the baby's birth and makes necessary repairs.